Okay, hello everyone. Welcome to Global Medical Education CPD webinar series. Um, First of all, I would like to um, apologize for on behalf of Dr. Silarani, who could not present today because of some family emergency. So we are very grateful to Dr. Rashid, who is a consultant respiratory physician who has agreed to chip in today to talk about sleep apnea, obstructive sleep apnea syndrome, very important topic for general physicians. And then our next talk is going to be on the topic of clinical reasoning in medicine. This webinar is recorded and it will be available on our YouTube channel. CPD certificates will be, the link to the certificate will be shared here after the second talk, and you can download it and save it for your portfolio. My colleague here is Dr. Mansoor Ali, who is the program coordinator, and we have attendees joining in. So without any further delay, I would like to invite Dr. Rashid to talk about sleep apnea and obesity hypoventilation syndromes and give us an overview on how to approach and how to diagnose and manage. Thank you very much.
Thank you very much indeed, Mansoor and Naseem, for inviting me for this presentation. Can you see my slides on the screen?
Yeah.
Okay. So although this is a pandemic and COVID is actually the most important thing to be talked about by the respiratory physician, I don't want to step on the toes of Professor Saralaya, who would probably want to give a talk on this at some stage. So I thought that I'm going to give you a talk on a much more common condition and has always been and would remain and probably going to become even more commoner. And I kid you not, it is a pandemic in its own right, because sleep apnea is, the prevalence of sleep apnea is now globally rising in prevalence with the rising obesity pandemic. And I will tell you some slides, show you some slides that will actually help to illustrate that statement. So sleep apnea is a condition that occurs in people who are predominantly obese or overweight, in which there is a recurrent obstruction or sedation of the airflow through the upper airways. And that occurs as a result of the collapse of the muscles that guard the inlet of the airways. Now, what happens when we sleep is that the muscles that guard, they also go floppy, just like the rest of the body muscles. The tone diminishes, they become floppy, and they can occlude either completely or partially the airway. So there is a cessation or reduction in the flow of air by more than 50%. And as a result of that, there is a drop in oxygen saturation. Oxygen saturation is a concept now, which has now become much more global, shall we say, because everybody is measuring their oxygen saturation in case they've got pneumonia with COVID. And therefore, everybody understands what that is. I'm talking about the layman. Now, this can occur throughout the night, and most people who have sleep disturbance, they go through a spectrum of conditions such as simple snoring, socially intrusive snoring, and that can lead to what we call an upper airway resistance syndrome, and a spectrum of hypopnea and then apnea, in which there is a complete flow of air when we breathe. What happens is illustrated in this diagram, that as the airway in the throat closes or partially closes, there is an obstruction to the flow of air. The breathing stops. If it completely stops, we call it apnea. But if there is a partial flow of air leading to at least 50% cessation, that is called hypopnea. And as a result of that, there is a drop in oxygen saturation. Anything between 3 or 4% or above is considered to be a significant oxygen desaturation. And that's sufficient for the brain to wake you up. But people actually don't wake up And these are what we call micro arousals, in which the sleep state becomes shallow. So when we go to sleep state 3 or 4, the muscles are actually all quite floppy, and we deep sleep, and all of a sudden the sleep fragments comes back to stage 1 and 2, often stage 0. And this person may not be therefore aware of these micro arousals. But as a result of that, the sleep gets fragmented. Now, as this brain wakes up, it breathes better, the muscle tone increases, the airway patency is restored, and the person is able to maintain his oxygen saturation. Before lot, the person drifts back to sleep. And as that happens, this happens again and again and again. So you can see this cycle goes on and on and on. And if I were to put an oximeter on a person's finger and record the graph, they record the readings, the graph will look something like this. And I'm going to talk you through this. If you look at this, 2200 hour is when the patient actually started the machine. And this dotted line that you might be able to appreciate represents 90% oxygen saturation. And this dotted line represents 70% oxygen saturation. The red graph is the oxygen saturation, and the blue graph is the heart rate. And you can see that both the red and blue, they are going up and down like a sawtooth appearance throughout. Now, this particular patient he went to bed at about 10 o'clock, but you can see that the oxygen saturations are hovering about 93, 94%. And at this point, this person drifts to sleep. And then slowly you can see that this oxygen saturation start to go up and down. And as you can see, these are every hour of the recording. So at 2300 hour, midnight, 1 o'clock, he probably woke up to go to toilet at this point, or something happened, the oximeter came off the finger. And then again, you can see throughout the night, and this is nearly 6 hour worth of sleep study, in which you can see that the oxygen saturation is going up and down throughout the night, every hour of the sleep. And in this particular individual, the rate of oxygen desaturation was estimated at 67 events of desaturation per hour of sleep. This is quite a severe obstructive sleep apnea. Now, what is important is that every time the oxygen saturation drops, it stimulates the catecholamines, the renin-angiotensin system that activates the adrenaline, and adrenaline causes heart rate to go up. So you can see there is a heart rate variability associated with it. Every time there is a hypoxia, the heart rate goes up. And as soon as the oxygen saturation is restored, the heart rate goes back to normal. And this is quite a typical graph of a person with a severe sleep apnea, recurrent drop in oxygen saturation and heart rate variability. Now, if you were to put the oximeter in a person with a lung disease, such as COPD or interstitial lung disease, they often have a very low oxygen saturation, but the graph wouldn't go up and down in a sawtooth fashion, and they wouldn't have this recurrent heart rate variability. So a simple oximetry will actually pick up the condition in vast majority of the patients. And this is the snapshot of a whole night of sleep. You can see throughout the night, the red line showing vast, and in some occasion, you can see that there is a cluster here where the saturations are actually dropping well below 70%. And again here, and these are almost certainly REM-related oxygen desaturation when there is an autonomic paralysis, in addition to the obstruction, so there is no flow of air whatsoever. Now, depending upon the number of the oxygen desaturation that occur in an hour of the sleep apnea could be classified into mild, which is 5 to 15 events per hour, moderate, which is between 16 and 30 per hour, and anything above 30 is considered quite severe obstructive sleep apnea. Now, in terms of the nomenclature, you can see that I've actually put a couple of other nomenclatures. AHI, apnea hypopnea index. So that is the number of apnea and hypopnea which we can identify per hour of sleep. And this is typically seen in the respiratory polygraphy or respiratory variable sleep study, in which we can actually detect hypopneas just as well as the apneas, because we have got nasal airflow probes, we've got a chest measurement. But in the simple oximetry, we can only give oxygen desaturation index, and often we call them respiratory events. Now, like I said, that when there is a recurrent oxygen desaturation and there is a recurrent arousal during the sleep is fragmented, and the sleep is actually not serving the function of refreshing our mind. So when the person wakes up in the morning, the person is completely unrefreshed, as though they haven't had any sleep at all. They feel exhausted, they feel tired, they get there. It's difficult to get them to get their head around. They need a couple of cups of coffee. And throughout the day, they actually feel tired. They find it difficult to focus and concentrate, pretty much like the junior doctor who have had a on-call overnight duty, and they are struggling to stay awake during the course of the day. They're pretty much like that, because the brain really hasn't been refreshed. They often find that they fall asleep easily when the opportunity presents. And this daytime sleepiness could be actually measured by an Epworth sleepiness questionnaire that invites them to answer simple questions such as their likelihood of falling asleep watching television, or reading a newspaper or a journal, or sleep after lunch, sitting to rest after lunch, or lying down to rest after lunch. And sometimes even in the company of a person, sleep sat talking to somebody, people would actually fall asleep. One of the common symptoms, of course, is the irritability that they get in their personality. They find it difficult to focus, their attention span is reduced, they are unable to concentrate, they are unable to perform their job as well as they would like to. And I've seen people, as a result of that, losing their business, losing their jobs, and so on and so forth. A frequent symptom is nocturia. Through the night, they can also wake up with choking and gasping episode. Often the partner or the spouse will tell them that they wake up with the snorts, and the snoring isn't particularly loud. Snoring is probably one of the commonest symptoms that brings them to us. To put you into context, sleep apnea is not the commonest cause of snoring, but virtually everyone who has sleep apnea would snore. Nearly 40% of the men who are aged above 30 would snore, and nearly 30% of the women aged 30 plus would also snore. But the prevalence of sleep apnea in the common population is about 4% for men and 2% for women above the age of 30 till the age they achieve menopause. Because after menopause, the protective effect of the female hormone is lost, and the prevalence becomes very similar to those of men. In men, they often experience diminished libido, erectile dysfunction, and in my clinic, one of the common causes of marital disharmony is actually sleep apnea. You would argue that communication or the lack of it is, but I would tend to disagree. I think it's the snoring which puts them separate. Often they sleep in separate rooms. And eventually, once they've had enough of it, they will come to us, or somebody will actually draw their attention to the fact that it could be easily treatable condition. So let's make a diagnosis. Now, like I said, that the vast majority of the people with sleep apnea are at least overweight, if not obese. So this obesity pandemic has had an impact on the prevalence of the sleep apnea. Nearly 90% of the people who have got sleep apnea are overweight or obese. And I've got some very latest figures from the House of Commons library, a briefing paper from January of this year, actually, which shows something very alarming. Now, this shows, if you look at this part, that nearly only 30% of the men are actually of normal weight. nearly 41% of the men in UK are overweight, which is body mass index between 25 and 30, and 27% carry a body mass index greater than 30, that is, they're obese. The figures for the women are 31% are overweight and 29% are obese. So really, amongst men, 67% of the men are actually at least overweight, if not obese, and 60% of the women in UK. If you look at the North American figure, they are much worse. Nearly 70% of the women and nearly 75% of the men are at least overweight or obese. The problem is actually much worse in that country. Now, if you look at this graph here, you could see that the age-wise, the incidence of obesity is probably highest in the age bracket 65 to 74. And you can see that the women catch up with the men as the menopause. So the highest incidence of obesity is in the age group between 45 and 75, where the prevalence increases from 4% to nearly 15 to 20%. One of the alarming things is that 1 in 10 children were obese by the age of 5, and 1 in 5 were obese by the age of 11, which basically tells us a lot what might happen to them as they grow. So this is what I've told you already. 67% of the men are overweight. Those amongst us who are of the normal weight are now currently in the minority. Now, this slide gives a lot of information. I'm going to spend a little bit of time on this, and if you want to keep a record of that. Overall, in the population, nearly 4% of the men and nearly 2% of the women of the age of 30 have sleep apnea. But I've also told you that nearly 90% of the people who have sleep apnea are overweight or obese. And therefore, it's hardly surprising that nearly 40% of those who are obese have obstructive sleep apnea. So people who are doing clinics, assessing patients for general anesthesia, if they think that a person looks obese, checking their body mass index is probably a wise thing to do. And if they are, then it is entirely reasonable for them to have a referral for a sleep study. Like I said, that the incidence of overweight and obesity rises with age, and above the age of 70, up to 20% of the people have obstructive sleep apnea. This is far worse than diabetes, hypertension, and ischemic heart disease put together, 5% each. 77% of those people who are morbidly obese, that is body mass index above the 50 cutoff, they have obstructive sleep apnea. And in my sleep clinic, this is a common occurrence. Referral to the community weight management team is often hindered by numerous problems, which are mostly political. Bariatric surgery, access to them is limited. I cannot refer patients directly to the bariatric surgery. They have to be referred either by the community weight management team or by the general practitioners. And if I ask the general practitioners to refer them to the bariatric surgeon, they say, well, why don't you refer yourself? Really, the geography determines what will happen to them. If you live in South, it is easy. You can get access to the bariatric surgery. But up north, it is not the easiest things to get. Now, one of the important things is the relation between sleep apnea and diabetes. And studies have confirmed that nearly 70% of those who are living with type 2 diabetes have some form of sleep disordered breathing. Now, sleep disordered breathing, like I said, that it could be simple snoring, it could be socially intrusive snoring, it could be upper airway resistance syndrome, it could be hypopneas or apnea. However, 80% of those who are obese with type 2 diabetes will have obstructive sleep apnea. Is it important to diagnose and treat that? It is absolutely important, and I will tell you in a minute why. But for those who are seeing diabetic patients, and a large number of my referrals are from the diabetologist, a large number are from ENT surgeons who see patients with snoring, and if they can't find anything, or before they do anything, they have to have a sleep study as a requirement from NICE to exclude sleep apnea, the cause of their symptoms. So those who see diabetics, those nephrologists who see people with diabetic nephropathy, if they are obese, it is entirely reasonable to get them referred to their local respiratory physicians to arrange for a sleep study in case they may have a easily treatable condition which has a significant impact on the quality and the life expectancy. Now, one of the important things that occurs as one achieve the body mass index above the age, above 30, that is to say, when they get obese, is a combination of obesity, sleep apnea, and type 2 respiratory failure. And that is what we call an obesity hypoventilation syndrome, or Pickwickian syndrome, as described in the Pickwick Papers by Charles Dickens in 1850. It is commonly seen in acute medical emergencies. People are admitted in AMUs, general medical ward, with what looks like an acidotic type 2 respiratory failure. They are commonly dubbed as COPD exacerbation, but when you look at closely and take the history, you find that they've actually never smoked. So why they've gone into type 2 respiratory failure? These are the people who have what we call obesity hypoventilation syndrome. Now, some of them may not have sleep apnea. They may just have obesity hypoventilation because of the effect of the restrictive effect of the obesity in their ability to ventilate will prevent them from excreting carbon dioxide, and they will have type 2 respiratory failure. However, a vast percentage will also have coexistent obstructive sleep apnea because this condition has a high prevalence in obesity group. And this is a bad combination. And I would invite—
2 minutes. 2 minutes, please. 2 minutes.
And I would invite the audience that if they were to see anybody with a type 2 respiratory failure, particularly the sharp end in the hospital, like A&E or acute medical ward, they must think about obesity hypoventilation syndrome. It's a common cause of admission with decompensated type 2 respiratory failure, and it is now the commonest cause of domiciliary ventilation. If they get admitted and they have NIV or non-invasive ventilation during their acute admission, they should not be allowed home without a follow-up sleep study in case they have this condition, which could be easily treatable. I just want to spend a minute on the metabolic syndrome, which is again a very important link, because this is the reason why sleep apnea decreases life expectancy, because there is a link between obesity, sleep apnea with hypertension, type 2 diabetes, and dyslipidemia. And these people, they have a higher risk of coronary artery disease, cerebrovascular disease, memory, cognitive problems, and increased mortality as a result of that. So I've spent some time on telling you what sleep apnea is, what obesity hypoventilation is, how common these problems are, both in the community as well as in the hospital settings. It is commonly undiagnosed and therefore untreated. In fact, there is evidence that vast majority of the sleep apnea in the community is undiagnosed. And what we see is only the tip of the iceberg. Like I said, it is easily diagnosed and it is easily treated. Vast majority of the people will improve their symptoms by just losing 10% of the weight. However, if you have got moderate or severe sleep apnea, you've got a lot of symptoms, CPAP is the way forward. And now again, in the pandemic naive world, CPAP is a common name. Everybody knows what CPAP is. I don't need to tell you what that is. Vast majority of the people will respond brilliantly. The obstruction will be overcome. The sleep architecture will be restored. They will have a restorative sleep. They will wake up fresh in the morning. They will wake up to a life they have never seen before. This is one of the interventions that has the most advanced or high level of impact on the quality of a person's life. Some people who would have type 2 respiratory failure may require non-invasive ventilation. A small percentage who are intolerant to CPAP, they can have what we call a mandibular advancement device. This is my last slide. So this is, again, the Department of Health, which shows that of the 1.5 million adults who may have obstructive sleep apnea, nearly 667,000 have moderate and severe sleep apnea. And if left untreated, it increases, the treatment of this condition increases their survival rate, it increases their quality of life and productivity, it reduces the incidence of stroke, cardiovascular events, road traffic accidents, and other work-related injuries. Thank you.
Thank you very much, Dr. Rashid. Excellent talk. We will invite our next speaker and then we'll take questions in the end. So our next speaker is Dr. Karadi, who has given a talk here in these sessions before. Excellent speaker. So I would like to invite Dr. Karadi. Thank you.
Prasad, it's actually there. Click on the fourth row on the third row, actually, fourth column on the right.
Yeah, it's there, clinical reasoning.
Prasad, clinical reasoning. So basically from the right, first, second, third, fourth, fifth column, third row.
Yeah, just there.
Just below Sam, Yeah, below Sam. Do you want me to share, Prasad? Prasad, you're on mute. We can't hear you.
Hello, everybody. I'm Dr. Karadi, one of the consultants work in Colorado and Huddersfield Hospital, and thanks for the invite. So Mansoor, can you share my slides yourself? I don't know where.
I'll do that. I'll do it. Don't worry about it. Yeah. Can you see that?
Oh, yes. Fantastic. Thank you.
Okay.
Okay. Yes. So yeah, let's begin with the, I would like to, I don't know if people are familiar with the word clinical reasoning. I thought it's best to start with a case and go through it, and then we can have some interaction. I don't know if interaction is possible here. If you can kindly use the chat option if you want to give your kind of thoughts on this particular case. So we have case number 1, who is a 22-year-old. These are all real patients that I've come across, and are good examples to illustrate about regarding clinical reasoning. So the first case is a 22-year-old who works as a betting manager, and he has been feeling unwell for a few weeks, lightheadedness, tiredness, nausea, and green color stools. He reports that he has changed to a healthy diet. He's only eating kind of mostly vegetarian and white meat, he said. So that was one of the kind of things he mentioned in the history. Examination-wise, systemic examination is fairly unremarkable, and the investigations are as below there. You can see the biochemistry profile, the full blood count, hematinics. So Yeah, I don't know if the interaction is possible here. So it will be nice to kind of get some opinion as to what would be your next step. What are your thoughts? What's happening here?
I mean, people can actually write chat box, that'd be great, just a few answers, or is it possible to unmute attendees?
Hang on. Ask all to unmute. Okay.
Yeah.
So anybody wants to comment, raise hands, and I'll unmute you. Anyone? I think I can see that patient is anemic. That's
Yes, yeah. So yeah, so the key thing that is, yeah, I think we've got a few responses there, low iron and B12. That's really good. So yeah, what would be the next step for this chap's management? How would you treat him? Would be the next question. And again, I'll give a few seconds if anybody wants to suggest. It might be further investigations or examination. Okay, celiac screen is a very good thought there. Okay. Yes. Okay. We go to the next slide.
Okay.
So yes. So the key things that are missing there are rectal examination, which is kind of mandatory in such a presentation. The initial rectal examination for this gentleman was within normal limits. There was no kind of evidence of melena. So there is B12 deficiency and there is iron deficiency. You can start the patient on iron replacement, B12 replacement to start with. But apart from the iron and B12 deficiency, something is not fitting in actually. And we'll go to the next slide as to what exactly happened with this patient. So he had two units of blood and was still feeling dizzy and lightheaded. The repeat hemoglobin on day 2, fortunately, was kept in the hospital with the pressures in the acute hospitals. The tendency to discharge patients is there. So fortunately, he was still in the hospital and his hemoglobin had dropped to 61. So we did a rectal examination again. On this occasion, there was frank melena and the urea had gone up to 7.6. And when we explored with the patient, he reported recent use of ibuprofen, and he had a quite an urgent OGD as an emergency, which revealed a duodenal ulcer with a bleeding vessel, and he had endoscopic treatment. He was started on IV PPI, and that was continued for 3 days and was discharged home, and he was fine. So what I'm trying to illustrate here is, if we move to the next slide, is the decision making. So there are 2 types of decision making that we make as clinicians generally. One is what we call as a system 1 thinking, where you just link the obvious kind of finding. For example, in this case, B12 and iron deficiency are standing out. You say this patient has got B12 and iron deficiency. I'm going to treat him with B12 replacement, iron replacement, and we could get him home straight away and see him in a week's time, for example, with repeat hemoglobin. But having said that, if you go back to the case, his MCV was normal, and with B12 deficiency, you would expect the MCV to be high, which doesn't fit. And again, you could argue, is it a mixed kind of iron and B12 deficiency that led to this? But he was feeling lightheaded and unwell as well. So the patient is very important. If he's not feeling, the patient is not feeling right, there's something happening there. And possibly a lying and standing blood pressure could have elicited a drop in the blood pressure. So that leads to the system 2 thinking. Yes, it could be B12 and iron deficiency, but having said that, there's no kind of macrocytosis. The patient is still unwell, is feeling lightheaded, and that kind of makes you think, okay, you analyze the information further and you consider the other possibilities such as a GI bleed. So these are the two main types of decision making. So moving on to the next slide. So why is it important, the decision making in medicine? So the decision making in medicine is important because the key things as clinicians that we do is make a diagnosis. That is the key. And when we have the right diagnosis, it leads to the right treatment, and the patient the patient's management is correct in that instance. Now, the diagnostic error, if you look at it, is one of the main reasons for medical legal kind of claims across the world. And the diagnostic error rate, generally speaking, in literature is about 15%. So we get it wrong about roughly between 1 to 2 out of 10 cases, every 10 cases that we see. So moving on to the next slide. So again, just to illustrate, if you look at all the medical legal claims, the diagnostic error is one of the most important kind of contributors to the medical legal claim. And when you look at what is contributing to the diagnostic errors, is it a system-related factor, or is it individual factors that is related to ourselves? And we notice that nearly the majority, in 3/4 of the case, it's the individual factors that are relevant. Moving on to the next case, sorry, next slide. So what is a problem here? Why do we make errors? Is it because we are not intelligent? The medical professionals are one of the kind of the cream of the students who get into medicine. And most of us are have a very caring attitude. Most of us working hard. So why does the errors happen? So moving on to the next slide, again, to illustrate the type 1 thinking and type 2 thinking. So if you look at this particular slide and I ask you what you can see here, and I'll give you a few seconds to look at this. When I first looked at this, it looked like a satellite image of something, or you can just say it's some sort of a sketch. But if people have seen it before, I think you'll be able to recognize what it is. So we'll go to the next slide. And you can see the vague outline of a cow there. Okay, so we'll go back to the previous slide. So now if you look at this slide, because you have seen the subsequent slide, which is the outline of a cow, you can actually see the cow on this particular slide. So this is what we call as type 1 reasoning. So when you initially look at this, if you have seen or been or come across the cow kind of outline before, you can easily recognize the pattern and say, yeah, this is a cow. So that's type 1 thinking. So brain has already seen the image and it automatically switches to the type 1 or the automatic thinking, which is quick and efficient. Whereas if you've not seen it before, then you go through the analytical model. Just to illustrate in a clinical sort of case, we'll move to the next slide. So if you ask a first-year medical student what they can see, they'll say some redness, some blisters on one side of the body in the posterior thorax, and they'll give the description. But if you ask a clinician who has been experienced, they can easily say this is shingles or zoster. So you still have. So that's how the type 1 and type 2 thinking happens. So going on to the next slide. So this is, I would like to give the credit for the next few slides to Dr. Pat Crosscarry. Is one of the leading clinicians who has done a lot of research on the clinical reasoning. And he describes this dual process decision making. So we have the type 1 thinking, which is the automatic one, or the heuristics. It's a mental shortcut where you've seen that shingles many times and you can automatically say within a few seconds that it is shingles. And the other one is analytical one, where you describe the unilateral dermatomal blistering vesicles. And then you come across to somebody mentions to you, this is classical of zoster, and that registers in your mind. So that's an analytical model. So both of them are not bad. So it's not like you have got a system 1 thinking, it's inefficient. So it is an efficient way of dealing with things, as long as what you're dealing with is a smooth road. So you can see on the first image, the cyclist is on a smooth kind of road. There's no kind of hardship. So you can resolve to the system 1 thinking and you don't have to worry. Whereas when you're dealing with a very complex scenario, as in the image number 2, it might be more useful to avoid the system 1 thinking, as we illustrated in the first case, where error could have happened, where you can just say it's B12 and iron deficiency. Whereas if you analyze it further, you can say MCV is not matching, it's not matching with the patient's presentation and the ongoing symptoms. Then you have adopted a more cautious approach and come to a conclusion, the right diagnosis eventually. Just to illustrate again, this is what we do in medicine all the time. So you've got the yellow box. In the yellow box is the initial problem. Your brain is a pattern processor. And if you have not recognized this before, you go to the down arrow, and then you go through the process. You you analyze it, you have guidance from a clinician or a senior person who guides you through that. And over a period of time, you're seeing 2 or 3 cases of, let's say, shingles, and that automatically comes to you and you become an expert in that. So that is how we learn lots of diagnosis through this kind of a processing model. So from type 1 to type 2. Again, this is another illustration. I think we can skip this slide for the fine reasons. So when you are presented with a case, so having a hang on, a step back, kind of in your thinking process is very important. Let me think over this once more. I know it's sounding obvious. Can we make sure that it is fitting with all the presentation? Is there anything that is not fitting with that, and whether we need to consider the differentials in that particular case? So just to elaborate on that, now we have got the idea of what is system 1 thinking and system 2 thinking. This is another case, which is slightly more complex, but a useful one to go through nevertheless. So we have got a 55-year-old gentleman. This is again a real patient who was admitted with witness seizures, recent diarrhea. His past medical history is of ischemic heart disease, peptic ulcer, and the medication lists are there. His adjusted calcium level is quite low, 1.35, which is very low. So he's been seen by a trainee. Just if you excuse me for a sec. Just a second.
While Prasad is away, Dr. Rashid, maybe we can take a question. There's a question that, is it possible that patients with sleep apnea do not report any daytime sleepiness? Sorry, I just muted you, sorry.
Yeah, it is actually not uncommon. A lot of people actually don't want to report excessive daytime sleepiness because there is a caveat here. If you say that, look, I fall asleep easily through the day and you drive for a living, your driving will be...
Apologies, I had to take that call, sorry.
Sorry.
So you wouldn't be able to drive, and the DVLA, you would have to report it to them. They will revoke license. So a lot of people who are cognizant of the fact that their license could be revoked, they don't report excessive daytime sleepiness for this reason alone.
I see.
I'll let Dr. Karadi finish and then I'll...
Yeah, thank you.
Okay, apologies, I had to take that phone call. It was an urgent one. So this patient had a repeated pulses of calcium gluconate intravenously over 24 hours, but still the repeat calcium is still very low. And so what is missing here? Again, I don't know if we can have the chat option for interaction. It would have been good to get some interaction. How do we deal with this particular case now? And some of the audience, if they have done the membership exams, they might be able to kind of think about this and suggest the next step.
Nassim, can you unmute them and probably just have a look at the chat box?
Yeah, so you can type in the chat box. And, okay.
Prasad, can we look into the causes of diarrhea, basically? Why?
Yeah, you can look at that. Yeah, that's a good thought as well.
Any other sort of actually electrolytes associated with calcium?
So
calcium sorry, someone said something.
Calcium is quite low.
Yeah.
So yeah, let's move on to the next slide. I think for that. So some of you might recognize, okay, yeah, is it because the magnesium is low and not corrected? Is that the reason why the calcium is still not coming up? So so this patient was given IV magnesium replacement. The calcium normalizes. Everybody is happy. The patient is discharged home. Let's move on to the next slide. The patient is readmitted a couple of weeks later with seizures again, and it's the same pattern again. Repeat calcium is 1.5, magnesium is not 0.2. The family is quite angry. Why is it happening again? Why this has not been dealt with correctly? So this is again a real case. So what is the problem here? And I'll give a few seconds for you to think, and then we'll go to the next slide. If anybody wants to hazard a guess and raise the hand, please do.
Any comments? Any?
Okay, there's no
I can see
response. So
low
we'll
growth
move
diarrhea.
on.
Oh, someone said something. Mohammed Rashid.
What's the parathyroid doing? And
Yes,
does he
so
got
that's
any
a good
history of
question. Yeah, that's a good question. So the
hyperventilation?
parathyroid levels were appropriately elevated for this patient, so it was not low.
And is there any history of panic attacks?
No.
Hyperventilation?
So we'll move on to the next
Is there
slide.
any other endocrine, multiple
Yeah, that's a
endocrine?
good. Yeah, it could be another endocrine related problem, or it could be calcium losing. Kidney disease, one of the suggestions, very good. So if you're losing calcium, calciuria, then that can lead to that. So when you go
There is a
back,
familial hypercalciuric
yeah,
hypocalcemia.
that is a possibility as well. So
Right.
when we looked at this patient and we looked at his medications, it's quite common. I think if you speak to a lot of endocrine people, they'll recognize this. So PPIs, there's a lot of literature, but they do cause hypomagnesemia. So this patient actually have shown 2 admissions. He had actually 3 admissions with the same problem: seizures, hypocalcemia, hypomagnesemia, and he had head injury with the seizure as well. So PPI can cause hypomagnesemia. So if you do a literature review, there are loads of reports of PPI causing serious problems, including seizures due to hypomagnesemia. So PPI was stopped and was switched to ranitidine. And since then, he has had no further admissions with similar problem. Now that we have seen this case, so what I'm trying to illustrate here is, although it's a complex case, because you have been through this case once, you have dealt with it, or you have found the cause and you've corrected it, the next time a similar patient comes, you automatically resolve to type 1 thinking, which is the mental shortcut or the heuristics or the automatic thinking. So you've been through the step 2 for that particular patient, type 2 thinking. And because you have done that, you can automatically resolve to type 1 thinking. So let's go to the next. We'll go to another case. I'm trying to keep it a bit more complex where we have had problems ourselves, because that's where the learning will be. So again, case number 3. This is to illustrate what are the individual factors that can impact on a management of a patient. So we have a 78-year-old lady who's been feeling non-specifically unwell, tired, heaviness in the head, also reports frequency in micturition, reduced mobility. Family have reported confusion. So key things to look at in terms of the investigations are the serum sodium is quite low, 124. The potassium is elevated, 5.6. Creatinine, as you can see, has got an element of acute kidney injury. CRP is significantly high, 166. Less than 5 is considered to be normal. White cell count is high with a neutrophilic pattern, and the hemoglobin is on the lower end of the normal, 110. So what next then? What are we going to do? How are we going to proceed with this lady? Is there any particular investigations?
Well, it's likely to be urinary tract infection here.
Yes, yeah.
Toxic confusion.
Yeah, confusion, frequency micturition with a high CRP, UTI is in the differential, definitely. And I would like to always keep it as a differential. It's very important that we keep it as a differential. Cortisol level, somebody mentioned, excellent. So hyponatremia, cortisol is very, very important because you don't want to miss on adrenal failure. TSH is very important. So this patient's TSH and random cortisol is normal. Urine culture is very appropriate suggestion as well. So that's really good. I think you're getting all the key things. What else is the key thing in differentiating hyponatremia in a patient? How do you kind of classify what type of hyponatremia it is?
Urine osmolarity.
Urine
Yeah.
electrolyte.
Yeah, urine osmolarity, serum osmolarity, more than anything else, urine sodium. Okay.
Yeah.
If the urine sodium is high, when somebody has low sodium in the system, the urine sodium, body should be trying to conserve the sodium. So urine sodium should be low. So if it is high and the patient is not dehydrated, we call it as inappropriate ADH secretion or SIADH, for example. And that has loads of differentials, including malignancy, infections, cerebral injury, brain injury, of infections, bleed, and things like that. So let's go to the next slide. So I think this was similar to what we thought. Sepsis, could it be urinary tract infection? Urine sodium is high, slightly more than 40. So we went through the CT scan because there's confusion as well. With the confusion, there's a thought of encephalitis as well. So this patient had lumbar puncture as well, which was within normal limits. White cell count is less than 1. On day 5, after intravenous antibiotics, the patient felt slightly better, but still unwell, still mobility is poor. The CRP has improved slightly, 56. White cell count is still high. And what next is the question. Where do we go from here? So this patient was discharged from the hospital at that particular point. Okay, and we'll look what happened to this patient next. The patient was readmitted a week later, this time with a more obvious frontal headache, significant headache, and unfortunately reported a bilateral visual loss. And the repeat inflammatory markers, the CRP was quite high, ESR was high, and this occasion was treated as giant cell arteritis, which was confirmed on a temporal artery biopsy. And the patient was given IV methylprednisolone followed by oral prednisolone. Unfortunately, giant cell arteritis is one condition where once somebody has visual loss, and it is a permanent visual loss, and despite treatment, the patient remained unfortunately completely blind. So again, when we go through this case, when we look at this, hyponatremia led to some differentials initially. There was high CRP, there was thought of sepsis, UTI. The improvement in CRP reinforces the diagnosis of sepsis. Encephalitis, we'll come to that, is in the differential, but usually with encephalitis, you have fever, which was lacking in this patient. And the CRP, if you look at the literature in encephalitis, usually on the low side, usually normal actually, CRP in most of the patients with viral encephalitis, which is odd.
2 minutes.
That's how you,
2 minutes.
That's how that's how you reach a diagnosis of encephalitis. So the lack of strong pointers towards the actual diagnosis, no headache, and what we call this as a premature closure or anchoring is one of the commonest reasons why diagnostic errors happen. Okay, move to the next slide. Next slide. Next slide, I think we'll skip that. So one of the things that I'd like to mention was, you know, there's a book on how doctors think, and usually a physician, you can check yourself. How quickly do we interrupt a patient? Within 18 seconds. That's the average. So when we ask the patient to give a history, we usually interrupt within 18 seconds. What they suggest is give the first couple of minutes to the patient, let them say whatever they want to. And most of the things that you want to ask or find out, the valuable information will be there in that minute or two. So we'll move to the next one. So again, I've illustrated premature closure in that case. We'll go to the next one for the lack of time. So this particular case, I would like to again mention because of the importance of the self factors there. So, we're going to give the diagnosis, sorry. So just to illustrate this patient with a chest pain, for example, who didn't improve with morphine, who did improve with morphine in ED, sudden onset, the heart rate is 80, blood pressure is 120, and hemodynamically stable, bloods are all normal, chest x-ray is normal. When you ask most of the trainees, the first thing that comes to the main mind is it, could it be ACS, could it be PE? So what I'd like to illustrate in this particular case is that always consider aortic pain in your differential as well, okay? So there was no past medical history for this particular patient, but later on we found that this patient had an aortic aneurysm that was reviewed by a cardiologist a couple of years ago and was waiting for a repeat echocardiogram. Because of the COVID-19 infection, the trigger was, oh, could it be PE because of the COVID-19, and went through the PE kind of pathway, and the aortic dissection was missed. So again, forcing yourself to consider the differential of aortic pain is one of the kind of learning point from this. Go to the next slide. And again, you cannot rely on pulse deficit, chest x-ray to diagnose aortic dissection. It's mainly your clinical suspicion. And what can help is the next slide. There's aortic dissection detection score, which you can use. And if the patient have any one of these kind of parameters, then you can use a D-dimer. And if it is negative, a majority of the patients didn't have a dissection, there are 2 or more of this, then you need to proceed to a CT aortogram straight away. So it's a useful thing to have in your differential and consider D-dimer. You don't need to do a CT aorta all the time. Okay, next slide, please. Again, for the lack of time. So this is a patient, I'll summarize very quickly. I'm not going to ask for any interaction on this. A 56-year-old builder, you're in a busy A&E, and he says he lifted some heavy object and then felt a pain in the left side of chest. And hemodynamically, overall, it looks fine. And the tenderness in the left lateral margin, bloods are fairly unremarkable, chest x-ray is normal. And in a very quick and busy kind of A&E, somebody can dismiss this as a musculoskeletal pain and discharge the patient. But if you focus and look at the details, the saturations are 93% on air, which is hypoxia in that particular case. And this patient actually had a PE, which was missed. So when we look at things, so we have looked at the cell factors like premature anchoring, premature closure anchoring. Then you look at anything, whatever we deal with in clinical scenario is dealt in the context. So if you have a look at this is a YouTube video on the square with the A and the square with the B look like different shade. When you actually remove the green cylinder, the A and B are exactly the same shade, because we are seeing in that, we'll go to the next slide. We're seeing in the context of the green cylinder, that's why the B is appearing as lighter than A. So whatever we deal with in the context. So next slide, please. Next slide, please. So we have got long wait number of patients to be seen. There is interruptions, fatigue, all these things, multitasking, and that impacts on our decision making. So sometimes when you're in that kind of situation, you can resort to type 1 thinking, which is a mental shortcut, and that's where you can miss that saturation of 93%. Okay, but obviously when it goes to a serious incident panel or mortality or morbidity meet, they are not dealing with the same situation. They're just looking at the contextual information and relaxed atmosphere, and they'll say, oh, why was this not seen, kind of thing. So next slide, I'll try and rush through the slides in the next minute. So for any error to happen, diagnostic error, you need the cell factors, which is the premature closure, anchoring, which we have discussed, and also overconfidence and lots of other things, which I've not went through. It's quite a number of things that can impact, which is related to our own self. Then there is a context, which is a second bucket, which is all the exhaustion, the number of patients waiting, how busy the place is, interruptions, noise, and things like that. And the actual task, the complexity. The more bad things are in each of these buckets, the more likelihood that you'll make an error. Okay. Next slide, please. So how do we improve? So what are the things to improve? Again, stop and think before you come up to a conclusion. Usually I encourage my trainees and myself to consider differentials. Even something looks very obvious, say, yes, let's have some differentials in the mind. Let's not, go for a single diagnosis. The next time, please give at least a minute or 2 for your patient. Listen to your patients before interrupting. That's very important. Having some sort of a thing that, examination is very important. Make sure you count the respiratory rate, for example. Those kind of forcing measures that you have is extremely important to come up with a diagnosis, the right diagnosis, and not to miss an unwell patient, for example. differential diagnosis, again, I mentioned. Over the course of time, we see how often textbook is so much different from what we see in real life. That comes with experience as well. And also looking at the probability of what various kind of investigations that we do, how useful they are. Is it enough to exclude a particular serious possibility of a serious cause of that illness, for example, with that particular evidence that we have? And pattern recognition and the pitfalls with that as well. And reflection is very important as well. And I keep learning. We are all making mistakes. Nobody's perfect. So reflection is very important. So last slide, I think it was shown to a lot of chest radiologists and asked what is the incorrect thing on that. And a lot of them picked the small nodule in the bottom, and there was just an artifact, gorilla, and that was not seen. So you only see what you're looking for. Thank you very much.
Thank you
very much.
Prasad. Thank you. That was an excellent presentation by both you and Dr. Rashid. Thank you. Thoroughly enjoyed the presentation. And I'm just going to actually probably a couple of questions for one for you and one for Dr. Rashid. In fact, actually, we're getting really compliments about excellent talks by both presenters. So Prasad, first for you, actually, a question. How can we improve on this clinical reasoning? Even if you're a senior consultant, you're still kind of actually bound to make some mistakes. But how is it that you can actually, yes, we work in a very busy environment, we work on busy wards, we have actually got 50 patients to see, sometimes 30 on your ward, and then you've got 20 outliers. You know, how can you, and you've got short staff, sometimes you come on a Monday morning, you've only got one junior doctor and yourself as a consultant. How is it possible? Do you have to kind of take work home? Do you have to come actually switch on to your computer at 10 o'clock in the evening and make sure you've checked the sodium, checked the urine, you've checked the MRI? How is it possible in today's day and age?
Yes, that's a tough bit actually, and over a period of time, Mansoor, we know where we have to spend more time with particular patient, and that's where the system one thinking, where you can use a system one thinking and say, okay, I'm happy with that, and where you have to do system two kind of analysis. That comes with practice, and that can save time. When you are using system one thinking, it can save time, although it can on occasions lead to error, but that comes with practice. Improving an environment atmosphere is very important, okay, because that's a neglected one, which is not addressed in many of the incident panels and mortality meets and all those things. They don't look at that much. You can never create the atmosphere of A&E there, for example. So making sure that you have enough people, or you're not overloading yourself, you're looking after yourself is also very important. Forcing yourself to think about other differential chest pain, I have to consider these three kind of major things. I don't want to miss aortic pain. I don't want to miss MI. And having that knowledge, okay, D-dimer can be useful in aortic dissection. It's just not for PE, but even in aortic dissection. Spending a bit of time looking at, one of the things I picked up is over the course of years is, and I'm sure you would have picked up as well, because if you just look at the last clocking, for example, and sometimes you go back to the first entry by the paramedics, and there's a lot of difference in what the paramedics have mentioned and what the first clocking has mentioned. Always spending some time looking at the kind of presentation, looking at the past history of the patient, and those kind of information is extremely useful. Reflection, there's no easy way around it. Is a thing really. So I think reflection, differentials, considering differentials, taking time before you make a diagnosis, going back to the patients you have seen as well.
Yeah,
revisiting
that.
Is very important as well. Yeah.
Excellent. Thank you very much. I'm sure there'll be questions and already lots of comments there. Dr. Rashid, one question for you that I have been sent through was, you know, I know you talked about, or you mentioned about obesity and obviously the metabolic syndrome, but the question is, I don't know the answer to that, whether it's right or not, but can OSA cause diabetes and hypertension? I know it probably could be linked with hypertension and OSA, but I'm not sure about diabetes as a cause as such, but you can elaborate on this.
Yes, absolutely. So first of all, I'd like to thank Dr. Cardy's excellent presentation. I think this type 1 and type 2 thinking was described first by this Nobel laureate. It's pretty much like Columbus discovering America. We always have known that the people have had a natural tendency which draws them to a quick, rapid, algorithmic thinking and those considered deep thoughts. And of course, how you maintain that um, depends a lot on the stimuli. So A&E consultant at the sharp end will always have the higher fraction of type 1 thinking as against people like me who will have a back door, particularly coming towards the later part of their career, and they will be more drawn to type 2 thinking because they have more time for that, and they're not really required to do as much time type 1 thinking. Coming to my point, the big elephant in the room, as far as I'm concerned, is not sleep apnea. That is the obesity. And that is the common uh, ultimate pathway, ultimate reason why people get all the problem. Obesity is the reason why people develop insulin resistance and type 2 diabetes. Obesity is the reason why people get increased in the bulk of the upper airways that prevents the flow of air in people who have got hypopnea and apnea and who snore and have a sleep disruption. And as a result, poor quality of sleep and a recurrent, repetitive kick of adrenaline through the night that occurs as a result of the recurrent episodes of hypoxia. And that is what causes the blood pressure to go up a millimeter or two every time they have a problem. So there is evidence that sleep apnea can itself cause 5 to 10 millimeter of sustained elevation of systolic and 2 to 5 in diastolic. But ultimate common pathway or ultimate reason behind all of these is the obesity. Obesity, as we know, is a metabolic syndrome itself in its own right. There is a derangement of metabolic pathway. So the lipid metabolism is impaired. Not just that, the dyslipidemia is probably the right word because you may have a low level of high density lipoprotein or a high low density lipoprotein or high level of triglyceride. All of them are just equally as bad. The insulin resistance itself, diabetes itself doesn't cause sleep apnea, but people who are obese are more likely to be diabetic. The incidence of diabetes is twice as much or in a person with sleep apnea as a person who hasn't got sleep apnea. So there is an independent association as well through an unknown mechanism, probably some sort of a metabolic mechanism, because sleep apnea is actually a systemic disease. There is evidence that this drives the inflammatory pathway. The recurrent episodes of hypoxia through the night triggers inflammatory pathway. Then there is elevated levels of leukotrienes and lymphokines in the bloodstream. So it increases a low level of chronic inflammatory process, pretty much like the one that you have in obesity. Obese people have chronic low level of inflammation in their body. And this is how they get linked in, which is why they're all dubbed in into what we call a metabolic syndrome of obesity, dyslipidemia, sleep apnea, hypertension, and diabetes. And this, at the end of the day, increases the cardiovascular risks and the cerebrovascular risk. Now, the commonest cause of death in the Western world is cardiovascular disease. The commonest cause of cardiovascular disease is smoking. Second most common is obesity. The second most common cause of death in the Western world is a stroke. The commonest cause is smoking. Second, obesity. Third most common cause is cancer. Commonest cause is smoking. Second cause, obesity. So you can see smoking and obesity are close. And I don't think we are winning either of these two battles, but clearly these are modifiable risk factors. And one of the main theme of my clinical practice is modification of the lifestyle choices. We will not be able to cure hypertension or diabetes. We can manage them, we can treat them, but we can prevent them by managing the lifestyle choices that we make, such as prevention of development of diabetes.
Thank you very much. Very elaborative, very descriptive. Thank you very much. I think I would have to actually thank both of you for your time and for the efforts. And thank you very much, Dr. Rashid, for stepping in the last minute. We will have a webinar in November. We're just going to actually work with the presenters for the date. And I hope I can actually get Professor Sarai to come and talk to us in November. Naseem, any final words for the excellent presentation today?
No, excellent presentations. Thank you, Ranga Prasad. Thank you, Dr. Rashid. and we have received some excellent feedback in the chat and also via emails. Both talks excellent, very good.
Thank you very much indeed.
And I'll
Thank
do
you.
the certificates for the presenters, and therefore for the rest of the audience, actually the certificates have been sort of shared in the link in the chat box. Thank you very much, and good
Thank you
evening.
very much. Thank you.
Thank you.
Bye-bye.
Bye.